Uh, the presentation is just in the sequence we got from you, sir. At first, it is the background, then objective, the challenges first, and how we conquered the challenges, about the work done and achievements, and the replicability of the model. Sir, we start from our background. Bihar State Archives Directorate, established in 1954, and it is under Cabinet Secretary Department. Initially, it was under Political Department in British period, but now it is in Cabinet Secretariat Department. It is the nodal agency of Government of Bihar responsible for upkeeping and management of government records. Bihar State Archives Directorate holds and preserves the historical records dating back to 1770 AD. Mostly the records are from British period, and some records are also from the Mughal period, and the rest of records are after independence. These records are made available to research scholars, different departments, judiciary, and to the public for their uses. But the organic nature of records makes them vulnerable and hence reduces their availability for reference purposes. And dissemination of information contained in these documents is essential for future documents because they are of our cultural heritage, and they are of historical importances, and we know the importance of records in the days today itself. One of the prime duties of Bihar State Archives is to conserve and preserve this vast treasure of age-old records through the application based on updated scientific archival principles and enhance their access to the public with a caution inflicting least damage to health of records. These records are of 300 years back, and many of the records are in brittle state. So it is the duty of, and it is the prime duty of archives to conserve these documents and to make all these documents public. Now, the initiation of the project, the Bihar State Archives is focusing on the conserving these centuries-old physical copies of records through the involvement of new scientific methods, including tissue lamination. There are two parts of conservation. One part, the conserving the old records and to enhance their life period. And at the same time, the other part is to make them digitized so that their lifespan could be enhanced. At the same time, it could be easily accessible to the world, for the public, for the purpose, for the use of public. They can access it from any part of the world. So the two most challenges things, the thing that creates challenge is to preserve the old documents and to make them public. Making the preserved records easily accessible in physical and electronic media, online, on-site, to anybody who wants to come study, research, or even enjoy with the help of internal documents management system and online web portal. Making a large number of old and fragile records, 300 years old, of administrative and historical importance, while making them accessible, available to the public, is a formidable task. Creation of digital backups and establishment of a framework of the digital preservation of historical documents with metadata in view of quick retrieval and long-term viability is essential, because we initially started making digital copies of these records, but we failed initially, because this is not only this is not only copying of any document. Copying of document or scanning of document is just like you are creating an ocean from another ocean. So the method of the digitization is a much more complex process, and to convert the analog in digital and the records in digital form is a formidable task and needs utmost care and the latest technology. Electronic management is the practice and maintaining the e-records of an organization, classifying, storing, securing, archival, and preservation and destruction of records. Long-term digital preservation is a secure method to ingest, process, store, manage, protect, find, access, and interpret digital information such that the same information can be used at any point of time. It should be preserved along the details which will facilitate the identification of origin, destination, date, and time of such electronic record. It should be preserved in such a way that it will remain accessible, reliable, authentic, and useful for the subsequent references. So initially, we have shortcomings in initiating these process, but later we become better day by day, and we started using the latest technology, or let me say the open archival information system. Our digitization is now based on open archival information system, through which we are in a better position, because we now our records are, when we digitize the records, it includes the metadata for quick retrieval and long-term viability. We face many challenges. Initially, organizational resistance to change due to lack of awareness and understanding of the new technology. Integration of new technology into the existing system was also difficult. High costs associated with the procuring and implementing the new technology, and lack of sufficient resources. Let me say, not paucity of resources was there, but yes, we have to go for lobbying, and we have to take our officers or senior officers or leaders into faith, so that we just make them aware about the program, and we after that we could secure the resources. There are technical difficulties in implementation of new technology, lack of training and support for staff members to use the new technology. It was time-consuming process of migration of data from old to new system, and data security and privacy was also very important. Recruitment of, but we conquered these challenges by recruiting qualified workforce in terms of manpower, facilitation of necessary training, exposure, and a motivational session for human resources, obtaining necessary assistance from specialists and nodal institutions such as National Archives of India. We regularly sent our staff to National Archives of India and other places for exposure and training purposes. We also invited a group of experts from National Archives to train our people and our staff. Getting the authorities on board by showcasing them the project's worth, it was very important. Initially, we have to go for all these things to secure their support. Securing the necessary budget fund for purchase of equipment, creating necessary resources, and successful implementation of the project. Establishing the partnership with the expert agencies for procuring certain services, and creating frameworks and mechanisms for monitoring the outputs. These are the process. These are the road pathway through which we used to travel to conservation, from conservation to digitization of our records. Now, during 1963, we are conserving 390 pages annually. We got a record of 1963. As we represent archives, so we got a administrative report in 1963, and on that time they proudly wrote they conserve 390 pages annually, but now we are conserving 10,000 pages each month, demonstrating the progress we have made. It is like that, and at the same time we are now digitizing 2 lakh 2 lakh folios per month. So we are now in a position to at least uh, more around about 25 lakh pages, folios, and till now, till date, 1.15 crore documents from the physical archives of record have been digitized, and more than 35 lakhs of them have been uploaded on the internal document management system placed on the Bihar State Archives local servers for online access. To date, 1.15 crore documents from the physical archives of records have been digitized, and more than 35 lakhs of them have been uploaded on the internal systems. With the implementation of conservation technique, more than 5 lakhs of brittle documents so far have been ready to be used for different purposes. Subsequently, number of brittle records has been reduced and have become less vulnerable to the threats of damage, destruction. With the aid of digitization of archived records and the implementation of DMS, the amount of manual work has been drastically reduced. The web portal has significantly enhanced the outreach and speed of access to material in the public domain, and that are now accessible on a global scale. The innovative aspects are attached with these are introduction of new scientific methods of conservation of papers in brittle shape, digitization of all conserved records for easy, fast, and long-term access, reduction in the need for manual labor in handling the conserved record, reduction of human touch to ensure maximum safety of the physical copies of centuries-old conserved records with the involvement of virtual system of accessibility, expansion of outreach with the deployment of online web portal, deployment of easy and quick data migration strategy, keeping up with the ever-changing technological aspect of the future, involvement of technological transfer of the modern era to improve dependability. We all know the digital form of recording is also very vulnerable. So it is very challenging to keep them in such a way so that they can be transferred to the other equipments in course of time as technology changes. So we are using NAS to preserve our data so that they can be transported with least damage. The project success may very well be replicated because it made use of cutting edge. We are as a nodal agency of government for management of records. So we are just disseminating what we have gained to other departments and universities of managing the records, and many departments like revenue department, registration department. We are supporting them for data management, for data preservation, for digitization, and at the same time we also go to the universities and to invite professors and students so that we could disseminate the information and awareness about the data, about the documents, and the technology to preserve them for longer period. This work has shown that digital preservation is viable option for long-term access and prolonging the useful of life of physical data. The online web portal also provides a wonderful opportunity to increase, scale up the global audience for the publication, records, and information of Bihar State Archives, which Bihar State Archives provides. In order to stay up with the quickly advancing technology characteristic of future, this project has also demonstrated the usefulness of quick and easy data movement solution, putting in place An internal document management system can help guarantee that all data is kept safely, securely, and for an extended period of time. The Bihar State Archives Directorate organized workshop every in every 6 months, and in this year we have trained 143 officers from 44 departments and 66 record keepers from 38 districts on this topic. Additionally, the archives working in the directorate was trained at master trainer. We also developed master trainer in our archives, and we also helping districts, record rooms, and districts to develop 1 or 2 master trainer for each record rooms. So we are, yes,
sir, please
we are.
conclude now. Sir, please conclude now.
Sir, this is the testimony of different persons from different part of world. They used to come, especially the Girmitia, the descendant of Girmitia laborers. They used to come to find their descent, their origin. So these are the testimony. These are the recorded statement of those persons. Thank you very much, sir. Thank you very much.
Thank you, sir. Very good effort for preserving these rare and unique historical records. Excellent work, sir. Thank you very much.
So you have recorded so many things. Is it possible to access all these documents online?
Sir, 35 lakh of documents. It is on our internal management systems, in our internal systems, and any person. But we are going to just, you can see, visit our website, and anyone can access our website and all these things. And after giving 5 rupees, they can get photocopy of these documents. Now it is available, 20,000 is available on our site, but yes, very soon we will be able to upload all these documents which we have digitized.
So why any fees is being kept? Because nowadays the world is open to everybody and it is free of cost.
Sir, it is very less. The amount is very less. It is 5 rupees only. But yes, if you see the amount, everywhere it is very much.
Amount is not an important issue. Suppose I am in USA and I want to access your database. So in that case, I need to pay ₹5 through my channel.
For foreigners, it is $1 for 1 page. Because okay, if you see, sir, if you foreigners, if they have to come in Bihar, they have to expend so much amount. So it is very less, and the
okay,
system.
I got it, sir. Your system is not free of cost. Somebody needs to pay to access your database.
Yes, but it is a very less amount, sir. Minimal amount we have charging.
Okay. That we got it. Second thing is, suppose I am in Uganda and I want to have a copy of your documents. So will it be possible for me to get this document in Uganda?
Yes, sir, it is possible. You can download.
Okay, downloading. There is no charges for downloading?
No, sir. It is chargeable. Our portal, you can go on our portal and you pay, and after payment you can download.
Okay, but sir, so many research scholars, they also use so many type of data, and if we put some cost on it, maybe this is not a novel idea. And nowadays, if we want to spread our knowledge and things to the world, perhaps okay, this is basically a call which state government has to take. Anyway,
token amount, it is a less amount, sir. and there are so many expenses being done. So
Okay.
anything if you give free, so then it loses its importance. So there should be some charge. So it is a very minimal charge, sir.
Okay, my observation is that the moment you put some charge, then it becomes very complex and the people shy away and don't use that services.
Sir,
Anyway, it is
sir,
your project. Thank you. No specific comment on that. Thank you very much.
thank you, sir. Thank you very much, sir.
प्लस हमने सिटी इंट्रा सिटी बसेस के लिए पब्लिक ट्रांसपोर्ट के लिए बस स्टॉप सिटीज में बनाए। बस स्टॉप पे हमने बसेस का टाइमिंग शेड्यूलिंग रखा है, किस रूट पे किस टाइमिंग पे कौन सी बस आएगी। वुमेन सेफ्टी के लिए हमने बसेस में पैनिक बटन, कैमरा, जीपीएस से एनेबल्ड बसेस है, और ये बसेस कंट्रोल एंड कमांड सेंटर पे भी इनका रूट और प्लस शेड्यूल देख सकते हैं कि किस रूट पे किस स्पीड से ये रन हो रही है। प्लस इसमें प्रॉपर इसका मेंटेनेंस होता है, ड्राइवर्स की ट्रेनिंग होती है, और प्लस उनको अगर वो कुछ अच्छे से बसेस उनका मंथली ऑपरेट होता है तो उनको रिवॉर्ड भी पॉलिसी हमने बना रखी है जो प्रोवाइड करते हैं। प्लस इसमें जो बस ऑपरेटर है उनको 40% वीजीएफ का भी प्रोविजन रखा है कि 40% हम वीजीएफ देते हैं मैक्सिमम बस प्रोक्योरमेंट के लिए, और मिनिमम कंपटीशन रहता है कि वो कितना हमसे डिमांड कर सकते हैं। प्लस जो प्राइवेट ऑपरेटर्स की मोनोपोली होती है कि वो फिक्स टाइम पे बसेस ऑपरेट नहीं करते हैं, जब पूरा बसेस फुल हो जाता है तभी ऑपरेट करते हैं, तो उसके लिए भी हमारा प्रॉपर टाइम शेड्यूल है। आप इसमें ऑनलाइन बुकिंग भी कर सकते हैं, भले ही कितने भी पैसेंजर हो, मगर बसेस एज पर शेड्यूल ही ऑपरेट होती है। प्लीज शेयर नेक्स्ट जी। इसके लिए सबसे पहले हमने पॉलिसीज बनाई थी, डीपीआरस बनाई थी। डीपीआरस को फिर हमने स्टेट लेवल टेक्निकल कमेटी से अप्रूव करवाया। फिर उसके बाद एसएचपीएससी होती है जिसमें चीफ सेक्रेटरी सर अप्रूव करते हैं। प्लस हमने इसमें पैरेलल 2-3 आरएफपी बनाए, जिसमें पहला एक आईटीएमएस वाला था, फिर एक बस ऑपरेटर वाला था, और एक एडवर्टीजमेंट वाला था। एडवर्टीजमेंट का हमने इसलिए रखा था कि अगर बस ऑपरेटर को फेयर से अर्निंग नहीं होती है तो उसमें बसेस पे जो एडवर्टीजमेंट या तो अंदर टीवी स्क्रीन होती है, या जो बस के बाहर बॉडी पे जो एडवर्टीजमेंट होता है उसमें उनका 80-20 शेयर था। 80 वो खुद रखेंगे, 20 गवर्नमेंट के साथ शेयर करेंगे। हमने सिटीज में जो बस स्टॉप बनाया वो भी पीपीपी मोड पे बनाए। उसमें कोई भी अगर आके बस स्टॉप डेवलप करेगा और उसको 7 ईयर के लिए एडवर्टीजमेंट राइट्स मिलते हैं। इसमें दोनों का विन विन सिचुएशन ये रहता है कि सिटी को एक इंफ्रास्ट्रक्चर मिल जाता है बस स्टॉप का, और हमको एक जो उसको डेवलप करता है उसको उस पर एडवर्टीजमेंट राइट्स मिल जाते हैं 7 ईयर्स के लिए, और वो हर साल 10% फिर उसमें जो उन्होंने रेट कोट किया उसमें इंक्रीज करके देते हैं। प्लस बस टर्मिनल का भी आरएफपी, और फिर जो डिफरेंट डिफरेंट सिटीज में जो बसेस ऑपरेट हो रही है उनका इंस्टीट्यूशनल स्ट्रेंथ मैकेनिज्म ट्रेनिंग प्रोग्राम भी हमने इसमें स्टार्ट किया था। प्लस हमने इसमें सिटी लेवल पे एक डेडिकेटेड अर्बन ट्रांसपोर्ट फंड भी डेवलप किया है, जिसमें जो आउटडोर मीडिया एडवर्टीजमेंट हो गया, पार्किंग हो गया, इससे जो अर्निंग होता है वो डीयूटीएफ में जाता है, ताकि सिटी भी फाइनेंशियली सेल्फ सस्टेन हो सकती है, कि अगर उनको अपने लेवल पे भी कुछ अगर इंफ्रास्ट्रक्चर डेवलप करना है तो वो गवर्नमेंट के फंड के ऊपर पूरा डिपेंडेंट ना रहे। नेक्स्ट। एमपी में एमपी स्टेट रोड ट्रांसपोर्ट कॉरपोरेशन 2005 में जो क्लोज हो गया था, उसके बाद प्राइवेट ऑपरेटर का ही मोनोपोली था कि वो जिस रूट का उनके पास परमिट है वो उसी रूट पे ऑपरेट करते थे, कोई टाइम शेड्यूल उनका एज पर था नहीं। प्लस फेयर भी उनका फिक्स था नहीं कि यही फेयर उनको लेना है। इसीलिए फिर 2014 में गवर्नमेंट ने ये विजन डॉक्यूमेंट में था कि हम ये इंटर और इंट्रासिटी बस स्टार्ट करेंगे। तो इस मॉडल को स्टार्ट करने के लिए हब एंड स्पोक मॉडल नाम दिया गया। मैं नेक्स्ट स्लाइड में आपको ब्रीफ कर दूंगा वो क्या है मॉडल, प्लीज नेक्स्ट। हब एंड स्पोक मॉडल में हमने ये रखा है कि जस्ट लाइक जो व्हील होता है उसका मेन पॉइंट जो रहता है वो हब है, और उसके पास पास जो स्मॉल टाउन या सिटीज है वो उसके स्पोक्स हो गई। और सेम हमने इंट्रा सिटी में भी यही किया। इंट्रा सिटी में भी जो मेन सिटी सेंटर से पूरा सिटी एरिया कवर किया, प्लस इसमें ये भी हुआ है कि दोनों इसमें पब्लिक को कनेक्टिविटी मिली है, इंटर भी मिली है प्लस इंट्रा भी मिली है। पहले ये था कि केवल हमारी बसेस विद इन सिटी लिमिट ही ऑपरेट होगी। अभी लास्ट ईयर 2021 में हमने ट्रांसपोर्ट डिपार्टमेंट से ये भी अप्रूवल लिया कि हमारी बसेस सिटी लिमिट के बाहर 25 किलोमीटर तक भी जाए, उसको भी हम एज ए इंट्रा सिटी ही करेंगे कैलकुलेट। वो इसीलिए क्या है क्योंकि बहुत सारी फ्लोटिंग पॉपुलेशन होती है जो सबअर्बन से सिटी एरिया में आते हैं वर्क करने के लिए, तो उनके लिए फिर स्पेशली इंटर सिटी का हमको परमिट लेना पड़ता था, जो कि फिर परमिट में इशू होता था। तो ये हमने ट्रांसपोर्ट डिपार्टमेंट से एक अप्रूवल करवाया कि जो गवर्नमेंट के अंडर बसेस चल रही है उनको सिटी लिमिट के बाहर भी 25 किलोमीटर तक ऑपरेट करने की परमिशन मिल जाए इंट्रा सिटी बसेस पे। नेक्स्ट, ये अभी हमने एमपी के 20 डिस्ट्रिक्ट्स इसमें कवर किए हैं। 20 डिस्ट्रिक्ट्स जो हैं ये एज अ हब हैं, और अभी पूरा स्टेट का अप्रोक्स 75 to 80% हम एरिया कवर कर रहे हैं इंटर सिटी बसेस से। और इन 20 डिस्ट्रिक्ट में से अभी हम 16 डिस्ट्रिक्ट में इंट्रा सिटी बसेस तो ऑपरेट कर ही रहे हैं, जो कि अभी इससे पहले इंट्रा सिटी बसेस ऑपरेट नहीं थी। नेक्स्ट, अमृत में ये जो हमने प्रोजेक्ट स्टार्ट किया था हब एंड स्पोक मॉडल, इसमें गवर्नमेंट ऑफ इंडिया का जो अमृत स्कीम है उसमें एक अर्बन ट्रांसपोर्ट कंपोनेंट था, वो भी इसमें ऐड किया है, जिसमें स्टेट, सेंट्रल और यूएलबी तीनों का शेयर था। वो अमाउंट हमने एज अ बस प्रोक्योरमेंट के लिए यूज किया है। और एक हमने स्टेट फंडेड डीयूटीएफ भी बनाया था। वो पूरा स्टेट फंडेड बजट है जिसमें सिटी खुद अर्न करती है और हमको स्टेट से भी फंड मिलता है। नेक्स्ट, ये जो बसेस हमने इसमें स्टार्ट किए इंटर और इंट्रा, इसका हमने कलर कॉम्बिनेशन भी अलग रखा है, और इसके लिए हम मैक्सिमम 40% वीजीएफ देते हैं और 60% ऑपरेटर को इसमें लगाना पड़ता है। वीजीएफ केवल कैपेक्स में मिलता है, ऑपरेशन उनको खुद को करना रहता है। प्लस इसमें हमने एडवर्टीजमेंट और रेवेन्यू पास का भी प्रोविजन रखा है, और गवर्नमेंट की तरफ से इनको बस टर्मिनल, डिपो, बस स्टॉप, ये सब फैसिलिटीज हम प्रोवाइड करते हैं। नेक्स्ट, इसका बेनिफिट ये हुआ कि जो भी वर्किंग फ्लोटिंग पॉपुलेशन थी उन लोगों को काफी हेल्प हुई कि वो अपना डेली वर्किंग के बेसिस से सिटी में आके और फिर वर्क करके वापस अपने डेस्टिनेशन पे जा सकते हैं। प्लस वुमेन सेफ्टी के लिए भी काफी ये सक्सेसफुल रहा, क्योंकि सिटी लिमिट के बाहर जितने भी स्कूल हैं, कॉलेजेस हैं, वहाँ पे उनको या तो प्राइवेट व्हीकल पे या फिर और मैजिक ऑटो या उनसे जाना पड़ता था। तो अब हमारी बसेस वहाँ पे जा रही है। इसके लिए हमने स्मार्ट मोबिलिटी कार्ड, वन नेशन वन कार्ड, जो गवर्नमेंट ऑफ इंडिया का स्कीम है, वो भी लॉन्च किया है सिटीज में, कि आप एक ही कार्ड से अलग अलग मोड ऑफ ट्रांसपोर्ट में, क्योंकि कुछ सिटीज एज अ लास्ट माइल कनेक्टिविटी के लिए इसमें ई रिक्शा भी ऑपरेट कर रही है, जो कि वुमेन ही उसको ऑपरेट करती है। आप कार्ड से पेमेंट कर सकते हैं। प्लस इसमें इंफ्रास्ट्रक्चर डेवलपमेंट हुआ है कि सिटीज में बस स्टॉप का कंस्ट्रक्शन हो गया है, जो कि इसमें सिटीज को फंड नहीं लगाना पड़ा, ये प्योरली पीपीपी मोड पे हो गया। और एक ये बहुत ही रिलायबल और इकोनॉमिकल सर्विस है, क्योंकि इसमें फेयर भी ऑल टाइम फिक्स रहता है। ऐसा नहीं है कि अगर कुछ भी फेस्टिवल का सीजन आया या बहुत हेवी रश हो गया तो उस टाइम हमने लाइक प्राइवेट ऑपरेटर्स के थ्रू प्राइवेट ऑपरेटर जैसे इंक्रीज कर दिया। और इसमें लास्ट माइल कनेक्टिविटी के लिए हमने सिटीज में ई रिक्शा भी प्रोवाइड कर रहे हैं, जिसको वुमेन ऑपरेट कर रहे हैं। नेक्स्ट, इसमें हमने गवर्नमेंट ऑफ इंडिया और स्टेट गवर्नमेंट की डिफरेंट स्कीम्स को भी कन्वर्जेंस किया है। जैसे स्वच्छ भारत मिशन से हमने बस स्टॉप और बस स्टैंड पर टॉयलेट्स लगाए। एनयूएलएम गवर्नमेंट ऑफ इंडिया का जो स्कीम है उसमें हमने जो स्ट्रीट वेंडर्स और हॉकर्स होते हैं उनको स्पेस प्रोवाइड की है बस स्टैंड पे। स्टेट की जो स्कीम होती है सीएम इंफ्रा, चीफ मिनिस्टर इंफ्रास्ट्रक्चर फंड, उसका हमने यूज रिनोवेशन ऑफ बस टर्मिनल और बस स्टैंड के लिए किया है। अमृत में हम बसेस का ऑपरेशन कर ही रहे हैं। पीएमएवाई में जो बेनिफिशियरी होते हैं जिनके सिटीज में घर बने हुए, उनको भी हमने इसमें जॉब प्रोवाइड की है। वहां तक बस की कनेक्टिविटी भी है, प्लस वो एज अ लेडी ड्राइवर या लेडी कंडक्टर भी उसमें बस में जॉब भी कर रही है, ताकि उनको उनके घर तक कनेक्टिविटी भी मिल गई और उनको जॉब भी मिली है। और स्मार्ट सिटी मिशन के थ्रू हमने जो कंट्रोल एंड कमांड सेंटर स्टेब्लिश हुए, वहां से बसेस की मॉनिटरिंग भी हो रही है। तो गवर्नमेंट ऑफ इंडिया और स्टेट गवर्नमेंट की डिफरेंट स्कीम्स के थ्रू हमने इसमें कन्वर्जेंस भी किया है। नेक्स्ट, इंदौर में स्वच्छ भारत मिशन के थ्रू इंदौर जो लास्ट 6 बार से फर्स्ट आ रहा है, तो वहां पे जो सब्जी मंडी है वहां से जो वेस्ट निकलता है, उस वेस्ट से बायोमिथेनाइजेशन प्लांट स्टेब्लिश हुआ है, और उससे जो बायो सीएनजी गैस जो निकलती है, तो वो जो सीएनजी बसेस जो ऑपरेट हो रही है सिटीज में, वो उसमें एज अ फ्यूल वो यूज हो रहा है। तो ये कन्वर्जेंस का काफी अच्छा मॉडल और काफी सक्सेसफुल भी रहा है ये। नेक्स्ट नेक्स्ट स्लाइड। डेडिकेटेड अर्बन ट्रांसपोर्ट फंड जो सिटीज ने डेवलप किया है, उससे उन्होंने बस स्टॉप बनाए हैं, बस टर्मिनल बनाए हैं, बस स्टैंड में पैसेंजर वेटिंग एरिया बनाया है, डिपो बनाया है। बस स्टॉप जो बने ये प्योरली पीपीपी मोड पे हुए हैं। इसमें हमने जो कंसेशनर आता है उसको एडवर्टीजमेंट राइट्स दे दिए, जिससे सिटीज को इंफ्रास्ट्रक्चर मिल गया इसमें, प्लस इसमें उनकी अर्निंग भी होती है हर साल। जितना भी स्टार्टिंग में उन्होंने अमाउंट कोट किया था एसपीवी को देने के लिए, तो एवरी ईयर उसमें 10% का इंक्रीज भी होता है। नेक्स्ट। इंदौर में अभी 100 ई रिक्शा जो ऑपरेट कर रही है वो फीमेल ही कर रही है, प्लस 40 इलेक्ट्रिक बसेस भी ऑपरेट है इंट्रा सिटी रूट्स पे। और क्योंकि अभी ई व्हीकल का भी क्रेज धीरे धीरे बढ़ रहा है, तो चार्जिंग स्टेशन भी भोपाल, इंदौर, ग्वालियर, जबलपुर में हम स्टेब्लिश कर रहे हैं, अराउंड 217। अभी इनिशियल कुछ सिटीज में सिविल वर्क कंप्लीट होके इलेक्ट्रिक चार्जिंग स्टेशन डेवलप भी हो गए। नेक्स्ट। इससे पहले वाला स्लाइड, इससे पहले वाला स्लाइड जी। इसका की अचीवमेंट और फ्यूचर रोड मैप हमारा ये रहा। मेन अचीवमेंट की बीआरटी तो स्टेब्लिश हो ही गया था, मगर वहाँ पे अमृत के रिगार्ड अंडर जो बसेस आई है वो बीआरटी पे भी ऑपरेट हुई है। प्लस काफी सारी यूएलबीज में रेनोवेशन ऑफ बस टर्मिनल, बस स्टैंड और बस स्टॉप का स्टार्ट हो गया और कुछ में चल भी रहा है। लास्ट माइल कनेक्टिविटी के लिए काफी सिटीज में अंडर प्रोग्रेस भी है। भोपाल, इंदौर, जबलपुर जैसी सिटीज में स्टार्ट भी हो गया है। बायो सीएनजी प्लांट इंदौर, भोपाल में कंप्लीट हो चुका है। दूसरी सिटीज भी ये अभी डेवलप करने में अंडर प्रोसेस है, कर रहे हैं। एक अभी हम अमटा भी बना रहे हैं, ताकि एक अथॉरिटी हो सारी अर्बन ट्रांसपोर्ट का वर्क और दूसरे वर्क देखने के लिए एजेंसीज हो जाए। डीयूटीएफ को हम दूसरी सिटीज जो अभी मेन 20 हब सिटीज थी उसके अलावा दूसरी सिटीज में भी डेवलप कर रहे हैं, ताकि जिन सिटीज में अभी इंट्रा सिटी बसेस नहीं चल रही है वहां पे भी ये बसेस चल सके। और रिमेनिंग जो नेक्स्ट स्लाइड। इस मॉडल को गवर्नमेंट ऑफ इंडिया यूएमआई कॉन्फ्रेंस जो होता है 2018 में बेस्ट अर्बन मास ट्रांजिट का प्रोजेक्ट का अवार्ड भी मिल चुका है। और इसका हमने पूरा जो नाम दिया है, इसका सूत्र सेवा दिया है, जिसका फुल फॉर्म भी हमने बनाया है कि स्टेट यूनिफाइड ट्रांसपोर्ट रीडेवलपमेंट ऑगमेंटेशन, और सेवा का है सर्विस इक्वलिटी वैल्यू एक्सेसिबिलिटी। 2018 में इसका इनॉग्रेशन हो गया था और अभी भी सिटीज टेंडर करके नियर फ्यूचर और बसेस ऐड कर रहे हैं। जी, थैंक यू।
आपका प्रयास बहुत सराहनीय है और अच्छा है।
सर।
क्या आप ये शेयर करेंगे हमारे से कि आपके स्टेट में जो बस स्टैंड्स हैं, बस स्टॉप्स हैं, आपने प्रेजेंटेशन में बताया कि उनको भी पीपीपी मोड पे बनाने की योजना है, तो कितने बना रहे हैं, कब तक बनाएंगे?
सर, भोपाल, इंदौर, ग्वालियर, जबलपुर मीन सर अराउंड 10 सिटीज में तो पीपीपी मोड पे बस स्टॉप बन चुके हैं सर। और बस स्टैंड अभी पीपीपी मोड पे करने के लिए सर टेंडर अंडर प्रोसेस है। इसमें बस स्टैंड के लिए सर 2 से 3 सिटीज में पीपीपी मोड पे अभी उन्होंने टेंडर भी निकाला है। और बाकी सिटीज में जहाँ पे सर ऑलरेडी बस स्टैंड है उनका अभी सर रेनोवेशन होके ऑपरेशन में, और कुछ का अंडर प्रोसेस भी है, चल भी रहा है सर।
गुड गुड, थैंक यू प्लीज। क्योंकि आपका जो है ना, आपके स्टेट का एनएचएआई के बाद में सबसे ज्यादा पीपीपी में सड़कें बनी है मध्य प्रदेश में।
जी जी
तो काफी लंबा एक्सपीरियंस मतलब आपका पीपीपी सेक्टर में है,
जी जी
एज गुड एज दैट ऑफ एनएचएआई। तो
जी
काफी सराहनीय प्रयास है। धन्यवाद बहुत बहुत।
जी, थैंक यू सर।
Good effort, and I wish you all the best. No specific question.
To assure water supply for every rural household in India in adequate quantity of prescribed quality with adequate pressure on regular and long-term basis through functional household tap connection, that is FHTC, by March 2024. Actually, sir, in our state, Tripura state, before announcement or before implementation of Jal Jeevan Mission, our state government has introduced Atal Jal Dhara Mission on 28 November 2018 for the similar works. That means to provide functional household tap connection to every rural household of Tripura, including urban. JJM for only rural areas, and our Atal Jal Dhara Mission was for urban and rural areas. However, after introducing the Jal Jeevan Mission, Atal Jal Dhara Mission for rural areas has been merged with Jal Jeevan Mission. Before, prior to implementation of Jal Jeevan Mission, only 3.30% of household have been provided with FHTC, wherein the national average was on 14/8/2019 was 16.71%. At present, we have achieved 57.38%, 57.41% of household, wherein the national average is 56.14%. That means after implementation of Jal Jeevan Mission, we have achieved 54.08%, wherein the national average is 39.43%. This is the, sir, how we have achieved the FHTC coverage for rural household in the state of Tripura. This is the coverage. And sir, problem. Actually, the first problem was we have low base starting. That means only we have prior to implementation mission, only 3.30% rural household have been provided with FHTC, wherein the national average was 16.71%. And sir, to ensure community participation and O&M management of the water supply schemes, to overcome this O&M management, the Council of Ministers of Tripura State has approved the standard operating procedure and bylaw for operational maintenance with involvement of the Village Water and Sanitation Committee and other stakeholders. The operation and management can be done properly. Then to empower and develop human resources in the sector such that the demands of construction, plumbing, electrical, water quality management, and water treatment catchment protection, O&M, etc. Then the solution: achieving the objective through retrofitting of existing schemes and new schemes to provide FHTCs at minimum service level of 55 LPCD. Another is along with testing at NABL certified laboratories at selected locations, training of community members for and use of field test kits and sanitary inspection, etc. Regarding NABL accreditation of laboratory, at present we have 21 water testing laboratories in our state, out of which one is state level water testing laboratory, 8 are district level water testing laboratories, and 12 are subdivision level laboratories. All subdivision laboratories and state level laboratories are NABL accredited in the state of Tripura. Out of 8 district laboratories, 2 laboratories have been accredited by NABL, and for 6 district level laboratories we have applied to NABL for accreditation, and we hope that within 2 to 3 months remaining 6 district level laboratories will be NABL accredited. Then sir, formation of village level committee user groups who have been mobilized through institutional support agencies, and coverage converging with skilling program being undertaken by government of Tripura to ensure that adequate number of human resources get trained. Then next, sir, At present, around 4.5 lakh FSTC out of 7.41 household have been achieved in the state. 67 villages and one block level block have been covered with 100% connection. Then, sir, 1176 number of village water sanitation committee have been formed to ensure sustainability of the schemes. And in the state of Tripura, there are only 1176 village. And, sir, one plan have been prepared as per the guidelines, and the same has been uploaded in the online IMS of the JJ. Then, sir, what we did different, sir? Number one, sir, we have introduced decentralization of financial power and enhancing approval limits at district and state level, including administrative approval power. Technical sanction power has been enhanced. Then, sir, use of IT in monitoring and implementation of the scheme, including development of integrated management information system. Then we have also engaged ISS to generate mass awareness in village about Jal Jeevan Mission, community contributions and operational maintenance of the completed scheme. Inclusion of smart water meters and IoT system for measuring depth flow. Those smart water meters introduced in the selected villages as a pilot basis after completion, after providing FSTC to every rural household, we shall introduce the smart water meters. And then ensured women's participation by involving groups in water quality testing through FTKs. Then, sir, this is the, sir, graphically representation regarding improvement on coverage of FSTC from 2018-19 to 2022-23. From 2019, 2020 to 2020-21, 3 times achievement have been shown in the graphical representation. And then, sir, regarding schools, sir, we have 4536 schools in the state, and supply system, and the rest of the schools are covered by the sports sources, and it will be covered through pipeline by March 2023. Then, sir, regarding AWC, 5041 AWCs have been provided with piped water supply system out of 8,932 AWCs, and the balance will be covered by March 2023. Though the balance AWC at present is being covered through sports sources, that is Mark II water supply system and the filter systems. And the, sir, next in the, we are benefited in the some ways. Number one, online tracking of the scheme progress, administrative approvals, technical sanction and work allotments. 5,880 women from 1176 village have been trained on water quality testing using field test kit. Then 12 ISS have engaged who are working for generating mass awareness. Then more than 938 plumbers and 1058 electricians have been trained as workforce for O&M of PWSS. And, sir, on 2nd October 2022, Tripura has been awarded the first prize by the Ministry of Jal Shakti, Drinking Water and Sanitation, Government of India, for outstanding work under Jal Jeevan Mission for providing adequate and potable tap water supply on regular basis to rural households based on Functionality Assessment 2022 in the category of regularity among the states UTs having less than 60% household with tap water supply by a team from Ministry of Jal Shakti, sir. This is the, sir, certificate, and this is the award receiving pictures. Thank you, sir.
Very good progress, sir. In fact, from 3% coverage to, you have reached to over 57% coverage in just for 3-4 years. It is a really commendable job. Do you have some helpline or some consumer grievances help so that people can register their issues of just like O&M and low pressure, etc.?
Yes, sir. We have introduced the toll-free number 1905, and through toll-free number, any user can complain their issues, and we are trying to to resolve this issue within a short period.
Okay, okay. Good. In fact, you have covered 67 villages with 100% tap connections. And
Yes,
you still have to go up to 1176 villages.
Yes, sir. And by June 2023, hopefully we will complete all the villages. That means tap connection, FSTC will be provided for all the rural households, sir. By 2022, already tender has been issued and work order has been issued and work is in progress. We are sure we will complete this task by June 2023.
Okay. Thank you, please. Thank you, sir.
Thank you, sir.
Sir, you will be able to complete the work by June 2023. But what is the mechanism you have adopted for its maintenance so that the pressure in the lines is proper and the people get normal water supply?
Actually, sir, before implementation of the water supply schemes, we have a project report so that the water pressure in the tail end keep as per our norms. And regarding operational maintenance of the water supply schemes, in every water supply scheme, users committees are being formed so that they can take up the operational maintenance of the water supply scheme involving the 15th FC Tight Grant Fund.
So, so local level community needs to take up this maintenance work of their own?
Yes, sir. Using the 15th FC Tight Grant Fund and user charges.
Okay, this means then the work is not being done professionally.
No, that means operational maintenance work.
Okay, but since your villages are in very far-flung areas, so I think some expert advice is required so that
obviously,
future...
sir, PW department, that is drinking water and sanitation, will involve with this program, but the main initiative have to be taken up by the users committee. Obviously, sir, our engineers will advise regarding operational maintenance, etc. And hand-holding support, sir.
Okay, thank you very much. Good work.
Thank you, sir.
And I shall be presenting the implementation of DNB courses in J&K. This shall be the plan of presentation, the healthcare concept in J&K, broad structure, then introduction to DNB courses, problem statement, interventions, achievements, outcome, and deliverables. We shall be keeping our presentation very short, limited to 3 to 4 slides, and we'll leave more room for discussions or questions. That is the plan. Our almost 73% population lives in rural, very hard to reach, mountainous and difficult terrains, and with a wide array of geoclimatic conditions. We have middle level facilities, primary and secondary care, and we have health and wellness centers, PHCs, CHCs, district hospitals. Then we have GMCs. Now we had AIIMS like institution called Sher Kashmir Institute of Medical Sciences, and now one AIIMS coming up, and which provided a tertiary care. what we started with a few years back was strengthening the village system with ashas and strengthening health and wellness centers, strengthening PHCs and also the CHCs. But apart, there was a felt need that to avoid so many things which we discuss on day-to-day basis, like unnecessary referrals and reduce out-of-pocket expenditures, we needed some mechanism to strengthen our district hospitals. With this in mind, I'll go with a slight introduction. Ladies and gentlemen, as you know, J&K has been blessed with a lot of beautiful tourist spots, pilgrims and shrines. And with all these kindness that God has bestowed upon us, we have our own unique subset of problems, which are very unique to J&K. And we had to, find out our own ways, our own innovations to, move forward through those problems. And these health infrastructure workflows processes are very critical to achieve public health goals and wider developmental objectives in the healthcare delivery system of any institution or a system. Though tertiary care services in public health sector, J&K is largely a public health sector. Private sector has a very minimal role to play in our systems. Our public health system consists of one Sher-e Kashmir Institute tertiary care, aims like 2 medical colleges were there, and now 5 at that time when we started, the 5 district hospitals were upgraded to new medical colleges. And in spite of all this, there were so many districts. We had 22 at that time, now 20, which were very difficult to reach, and 6 to 7 months a year, they would be snowbound, inaccessible. Not, the weather would not be predictable, and they were devoid of these services. And those districts, and especially their district hospitals, would largely resort to first aid and refer to the tertiary care institutions and compound their problems, overburden those GMCs, which were already overwhelmed with their own load and the resources. So, keeping in view the geoclimatic conditions and the present distribution and availability of the specialized medical services of the districts at that time, the government of J&K very thoughtfully, in a comprehensive manner, tried to uniquely institutionalize a DNB project. So DNB is offered in many institutions and seen so many times, but here we attempted a unique institutionalization of equitable distribution of services as a major factor in mind, which would help the populations in around the year type of that system. The deployment of national board, as we all know, is equivalent to PG courses of MD and MS, and it also maintains very high standards of medical education. And you have to go through a journey to achieve even a single seat in any of the institutions. May it be a tertiary care institution or a secondary care institution. Problem statement, which is being faced in most of the parts of the country. There is always a scarcity of medical specialists and specialized medical services, overburdened tertiary care hospitals, scarcity or inequitable distribution of machine material and manpower, which leads to unnecessary referrals to level 2 and level 3 facilities. And once the families have to move out to the cities and larger cities for the treatment, there is exponential increase in out-of-pocket expenditure as well. So what we did, we constituted a DNB steering committee and implementation committee as an intervention. We deliberated at the highest levels of the government, took the executive director and the concerned senior officers of NB into the confidence, the ministry also into the confidence, and the NHSRC also with us. Then we identified the gaps in terms of buildings. We had to have 100 to 200 bedded buildings, and then we had to have infrastructure in place in terms of beds, those monitors, other machinery equipment. Then then the additional funds were worked out, and then as per NBE norm, the specialists had to be deployed, the nursing manpower had to be made optimized, and other manpower as well. And all those plans and micro planning were done. And there was, a dedicated official appointed as a nodal officer to look after all these things. And we had a very long journey of 4 years. Initially, we started with a few hospitals, like 8 hospitals. Then we expanded it to some more hospitals. Then, surprisingly, we could see that it had a scope in schemes like institutions, in GMC like institutions. There were also certain departments not teaching. And then the new medical colleges, the upgraded district hospitals into new medical colleges also had a scope. And then when we identified the districts which were eligible in terms of infrastructure and where we could give the manpower, we could surprisingly find out 2 CHCs, the 2 sub-district hospitals, which could have done it. And ultimately, with all these interventions, these were our achievements. You can see, ladies and gentlemen, in session 2020, 2021, and 2022, the number of seats went on increasing, number of institutions went on increasing. The candidates, because in between there was a long COVID period since the inception of, immediately after the inception of this project. And our district hospital at Jammu became first hospital to start and have a candidate. And ultimately CHC Kupwara, it's a very far-flung border district, very difficult district, where if we post a doctor, he would not go. Where if we post a doctor, he would resort to methods like obtaining stays and all. We could just, this month only, me and our health secretary went to see that hospital and see the effect of the DNB project. And there were 9 DNB students from all across the country inside the hospital, running 24/7 services, where even a single doctor posting would have been a very difficult task for us. And since the launch of DNB project, about 159 candidates from all over India have joined, and 39 from state quota have also joined. And 2 CHCs of our Kupwara and Sopur, they also have the candidates. I met with the candidate yesterday at Sopur as well. So the outcome and deliverables were the strengthening of district hospitals. There was increase in case mix. There was case retention. There was increase in case load, and there was a revenue generation in terms of Ayushman Bharat packages. Otherwise, they would not retain the patient. Patients would go away. Now they retain the patient. The revenue also comes, and the revenue reserves of, even when I go to visit some of the hospitals this month, I am visiting many hospitals of these DNB hospitals. I see the savings of Ayushman Bharat to the tune of crores. Otherwise, these hospitals will be cash starved. Now I can see optimized, specialized HR and medical care services available there, which were not there. And there is a better access to the healthcare in far off places, because the services are available to the closer to the people's homes, which otherwise would have been unthinkable before the start of this. Naturally, this reduced referral, out of pocket expenditure. Now the environments of these hospitals have changed drastically, because for achieving this teaching environment, you have to have some accreditation process as well in place. We subjected all these these hospitals to Kayakalp and NQuas, and there is now a beautiful departmentation. The quality processes on the prescription audit, like things going on. I saw at Baramulla yesterday. There's a sea change in the environment, which is very visible to anybody. And now this is the outcome. This project has been appreciated by the Honorable Prime Minister, the Honorable Health Minister of India. You can see, ladies and gentlemen. And a pleasant thing is that one of our DNB students, he got the highest civilian award of the state for his role during the COVID pandemic. And you can see that student. And you can also see a newspaper cutting where mostly we see at many places in the country, and on day-to-day basis, hospitals are in the news for some not right reasons. But you can see now very frequently on print, electronic, and social media, because of this DNB project, our hospitals are getting appreciated. Yes, a few days back, civil society members of an area, they had invited us to thank us for all these endeavors. And this, another thing which I would like to highlight is, if we have these medical colleges and schemes since last 50 to 70 years, and we could have only 600 PG seats. I was inquiring yesterday in the form of MD and MS till date. In last 4 years only, we could have almost 300 seats in the form of DNB. That too at the level of district and sub-district level. After stringent accreditations, the assessors coming from All India Institute of Medical Sciences like institute to assess these facilities and giving us accreditations. So this was a journey, ladies and gentlemen. Thank you very much. I am open to any questions now.
Dr. Mehta ji, very good effort. In fact, there are very few seats in the prestigious medical colleges also in case of MD and MS. And you have augmented this DNB course in your state. Definitely, it will further improve the educational standards of medical education in India. You have indicated in your presentation that 159 candidates from all India have joined this DNB course in your state. So they have to be physically present there. What is the arrangement?
Sir, this is a full-time PG course.
Okay.
Full-time PG course, just like MD/MS. They have to be
Okay.
physically present on roster duties, on OPD duties, and all kind of critical care duties, sir. And they have, we ensure the candidates which come from outside, we ensure their stay inside the hospitals as far as possible, sir. Their hostel
And,
facilities, their library facilities, everything.
And from the presentation last slide, you have indicated that 265 DNB PG courses seats have been approved for your state.
Yes, sir.
And 159 have joined. So do you want to further expand the reach to these all the seats?
Yes, sir. Definitely, there is lot of scope. Actually, we got huge number of seats with the efforts of last 4 years, with everybody cooperating, the ministry cooperating, the state government cooperating, the institutions cooperating. So we actually, the candidates have joined less because the time got wasted in COVID as well. Then we had certain other kind of problems here. Now the candidates have come from outside. This is going to be a big word of mouth that J&K has really a public sector PG teaching environment. So these seats, this number of candidates is going to get increased. And yes, I am on a review round of the J&K of all the districts these days, in spite of these -5, -10 temperatures here. I find 3 more hospitals, they have a scope for further way forward. And in fact, increase the number of specialties in these existing hospitals as well.
Dr. Mehta, last session,
please.
in fact, since you have implemented this DNB program in your state, successfully implemented, and soon it will create a large impact. Do you have any proposal to implement or encourage other states also to follow your model?
Definitely, sir. I can see visible changes. The referral rate went down by 70% in a very far-flung hospital. There are statistics available, and the qualitative improvement and the overall environment and the public confidence overwhelming, sir. I request some of the experts to visit our state for this. In fact,
Sure.
in one of the consultative meetings of the government of India, I recommended this to the other
Definitely.
states. Yes, sir.
Definitely, you invite them and make them feel that they need to implement this to overcome the medical specialist shortage in across India.
Yes, sir.
Definitely, you have to take a lead. Thank you,
so
Doctor.
much. Thank you so much.
Thank
sir.
you, Doctor.
Thank you.
So what are you doing to attract foreign national to take up these courses?
Sir, actually the things have moved so fast. I mean, the so many applications we filed. It was quite a load to handle all these applications simultaneously, because if you see the map of J&K, these are, distant places. Inspections going on, then, handling the things, putting things in place, putting hospitals in place, the HR, convincing them for this. Now we have attained this. There is always a way forward. And of course, the J&K is internationally famous for its other beautiful things, and we also expect that we can work on those areas as well, and that really has a potential. We will take it up with the ministry and concerned stakeholders and our government as well. Let's see where we reach, sir.
Okay, thank you.
Thank you so much, sir. Kind of you. Good day.
Thank you so much, sir. Now I would request.
I will be presenting electronic system for automation of hospital administration in J&K. Basically, it is an initiative of National Health Mission J&K, and we are being supported by TechJiva, a Pune-based software company. Next. Our contents will be like this: rational introduction, J&K SKOCH at glance, current status, our approach, dashboards and reporting.
Sir, your slides are not moving.
One second, sir. Here it is. Actually, I am.
Yes, yes. Now it is perfect. Please go ahead.
Okay. So basically, rationale for hospital management information system. Hospital and management information system has been implemented in UT of J&K. The project was executed on 18th July and initiated on 4th August 22, with an objective to streamline the patient healthcare system by streamlining operations in healthcare facilities, controlling, managing patients' registration, availability of electronic medical records of the patient, and to overcome irregular entries with respect to issuance of drugs and poor stock management with poor record keepings. So more significantly, it is also aligned up with Ayushman Bharat Digital Mission, which is an ambitious initiative aimed with an objective to integrate various public health care facilities to have a centralized management of medical record across the country. So there is actually a slight problem in sharing the slides. Coming to introduction, hospital management information system has been introduced in JK as a localized platform to read as an electronic system for automation of hospital administration in J&K and being implemented with technical support from TechJiva Private Limited Pune, as I have already informed. Scope of SKOCH: around 578 facilities, including 21 associated hospitals of GMCs, 15 district hospitals, 18 community health centers, and 48 urban primary health centers, with 41 new type of primary health centers have already been covered in the first phase of implementation, which will be extended to all public health care facilities. In first phase, up to 31st December, basically, 3 modules have been implemented. That is registration, OPD, and a pharmacy module, and it shall be scaled up to all the departments in phased manner. IPD module has been initiated recently, that is in January only. Single standard software modules of the patient registration, electronic medical record generation in OPD, IPD, and drug dispensing. It is a complete automation of hospital services, online registration of all the patients visiting healthcare facilities for ensuring digitization of record keeping, and it also gives a extension app for doctors to receive real-time listing of patients in their facilities. Functionality of providing SMS prescriptions to the patients, along with the functionality of the patients with feedback mechanisms. It is also integrated with a rapid assessment system, having an inbuilt digital feedback mechanism, generation of electronic medical record, patients visiting the healthcare facilities, integration with RCH portal to monitor the field ASHAs and A&M activities on a single portal. Seamless exchange of quality data, and we are also conducting ranking of all the public health facilities on key parameters like patient registration, feedback, and EMR conversion. What were our objectives? Like live performing monitoring across the centers. It also gives us governance around utilization of hospitals, digitalization and less paperwork, then centralized repository with health record management, integration to the various government portals with seamless exchange of data, and analyzing the disease around the UT, increasing decision-making abilities. So these were our objectives. So look, having a quick assessment, current modules implementation status. These were the 8 modules: registration, online and walk-in patients, then OPD, emergency and casualty, inpatient department, IPD, labor room, operation theater, pharmacy, and laboratory. We also added some services like RAS integration, SMS based feedback collection system, feedback mechanism integration with Mera Aspatal, mobile application for patients, doctors and pharmacists, and monthly performance evaluation, that is systemic evaluation of each center. So what have we done and what we have achieved so far? That is SMS services for transparency provided by CDAC. 3 SMS are delivered for each of the users. It has been done. Rapid assessment, as I have already informed, it has also been done. Integration with Mera Aspatal. Development of the module for 10 call center to collect the feedback for all the 578 centers. Then for associated hospitals, 13 registered with National Medical Commission, and API integration enabled to share the data. Then Excel-based automation integration setup, collecting RCH data for eligible couples, pregnant women, child immunization, need to create required support. It has also been done. ABA ID integration, we are under process for this. And Jan Aushidhi integration, that is also under process. TMS and gold card integration, it is also under process. Scan and share, we have completed first milestone of this. And then bank integration, that has not started yet. Implementation approach, we had 5 parameters for this. Initially setup period, that is setup of infrastructures in all the facilities. Then identify the challenges and various issues in the centers. We resolving the issues, configure the customized solution to adopt, and onboard resource on the platform. Like in challenges, we faced topographic and extreme temperature of Jammu and Kashmir, and with the security challenges of internet facilities at Indo-Pak border, or sometimes in the casualties in our disasters in the states. Then conducted physical training across the districts, user manual for each of the modules. There were planned trainings as well as request-based trainings were also, whenever required, we provided that, and we are under process. A few of the trainings are still left. Regional trainers available on ongoing services. This Pune-based company is providing us the trainers throughout all the 20 districts of Jammu and Kashmir. Then rollout process with 1 week, that is install all the infrastructure and application. Like we have achieved around 75 to 80% of this. Then security assessments and resolutions of initial findings, onboard of receptionists, pharmacists, doctors, nurses, etc. is in the system. Then the release mobile application on Google Play Store and iPhone of App Store. Set up, implement real-time dashboard, and set up backup and DR environment. Everything this is being conducted by Pune-based company TechJiva. Integrate and ongoing SMS integration, which I have already informed in previous slide. I'm not going to repeat this. Then coming to enhance ongoing, what are monitor real-time dashboards, support team to ensure active utilization of solution across the centers, 24/7 call center and support for applications, coordination with the infrastructure team for 99.9% uptime and SLA. How our dashboards and the reporting is being done. Like here we can see in our dashboard, this is summarized data, like all the centers, like 578 centers are there. How many of them are active centers? How many patients have visited, EMR conversions, medicine deliveries. Then we also have in UT ranking, like top 5 performing associated hospitals, top 5 performing district hospitals, top 5 CHCs, top 5 performing PSCs. This is how our dashboard look like. And reproductive child health reports are like this, like how many centers are there, how many of them are active, newly registered eligible couples, total number of patients visited, newly registered pregnant women, number of pregnant women visited, new childbirth, children immunized, and then women deaths and child deaths. Then we have monthly feedback scoring system and monthly center performance scoring, which is a review of all the hospitals based on this. And this is how we make ranking, review all the hospitals with 25% of patient visited, 25%
Sorry
of
to interrupt you, sir. Please conclude. You have 2 minutes more.
and 50% of feedback. Thank you, sir.
Sir, very good efforts. Particularly, I appreciate your this dashboard on which concurrent this evaluation is also being done. Do you have some feedback from the patients? How do they feel about this new IT system?
Yes, sir. They do give us feedbacks, and moreover, we have 104 call centers. Randomly we call them, and every day the call is going on. We have separate control room beside our NHM office, and regularly they are monitoring 24/7. People are working there, and they are randomly doing all the patients who are visiting to OPD as well as to IPDs.
Good, good. Thank you, Doctor. Thank you.
So in case any problem complaint is there, so how soon that complaint is being resolved?
So we have separate complaint cell for this thing, and if it is, we find any complaint, if it is technical based, then a technical team is there. TechJiva team is simultaneously working with us. If it is a problem through the hospitals, simultaneously the hospital administration is being called up and ask them to resolve the issues.
Okay, and second issue is what special facilities are extended to BPL?
So that we have not done so far, but we are in a process. We will definitely do that also, as we are going to incorporate Ayushman ABDM along with this procedure, whatever we are doing right now.
Okay, good enough. Thank you very much, sir.
Thank you. Thank you very much, sir.
Initiative as which is a technical partner for the National Health Mission, and I will be presenting the ODK application for gap assessment of public health facilities as per IPHS 2022. As we all are aware that Government of India, Ministry of Health and Family Welfare recently has released the revised guidelines for public health facilities, starting from the district hospitals up to the level of the sub-center level. And the Government of India has set the targets for each state that by 2025, they need to have 50% of their public health facilities as IPHS compliant. And as we all know that these are the standards against which we check the functionality of the public health facilities, and so as to ensure delivery of assured quality healthcare services. And these guidelines were first launched in 2007 and then again revised in 2012. And now latest guidelines have been launched in the year 2022 itself by the Honorable Union Minister on the 16th April 2022. And before the dissemination, national dissemination workshop was held by the Ministry of Health and Family Welfare in the month of November. The UT government, National Health Mission JNK, took the lead before that to have the assessment of its health facilities as per the revised guidelines, so as to achieve the targets of 50% compliance of public health facilities by 2025. The basic areas which cover this IPHS 2022 include human resources, diagnostics and equipment, drugs, consumables, medicines, and the quality improvements, various governance initiatives, and the infrastructure. Why this ODA? What is this ODA toolkit? The ODA toolkit, we developed this under the overall guidance of the National Health System Resource Center and the Ministry of Health and Family Welfare. It is an app-based system which can be accessed through mobile or the tablet or any computer system. The checklist was based on the guidelines, and it was digitized through the ODK toolkit, and it consisted of 10 sections having 75 subsections in it. What is the uniqueness of this ODK toolkit? It is an open data kit and is an open source mobile data collection platform, and allows data collection using Android mobile devices, or it can be accessed through any computer system from any web page. And data is stored on an online server and can work even in the offline mode. In the remotest areas, we know we have the remotest areas where the internet connectivity is not so good, and sometimes due to some disturbances, the internet gets out. So we could work even in those conditions because it gets stored in the offline mode. Whenever we reach in the internet zone, it gets automatically uploaded at that time. And it is a proven platform at all the global scale, and analyzes the data with ease. Why this? What was the need? Because as I already mentioned, that the state governments had, all the state governments and UTs have been given a target of 50% of IPHS compliant health facilities by 2025. So we had the limited time frame. So we wanted to achieve this in a very quick manner and to save time. So this ODK toolkit was developed with the technical support of the Norway-India Partnership Initiative, so that we could upload the data in real-time basis instead of filling the checklists and analyzing the data manually for each facility. So we could save time and minimize the errors, and also the recall bias. Then to identify gaps as per revised IPHS 22 in the assessed facilities, and formulation of action plan to address the identified gaps in making these health facilities as IPHS compliant. Then to have evidence-based planning and budgeting for all the future proposed in the state program implementation plan of NHM or the UT budget, which will be based on this assessment. So how we went ahead for this assessment? In the first phase, we selected the 13 district hospitals. Initially, we had around 20 district hospitals in the 20 districts of our UT, but these 7 district hospitals have been upgraded as the medical colleges. So we skipped those medical college district hospitals. So we selected only the 13 district hospitals which are actually functioning as the district hospitals. Then the assessors were identified by the NHM J&K for collection of data in these 13 districts. 7 teams were total constituted. Hello? Hello? Am I audible?
Sir, yes, you are audible. You please continue.
Yes, total 7 teams were constituted, having 3 members. 1 member each from 2 members from the National Health Mission, and 1 member was from the development partner, Norway-India Partnership Initiative. The teams were sensitized and oriented over a virtual meeting about how to use this ODK toolkit. And then the assessment design was a cross-sectional design, and data was collected, analyzed, and presented in tabular and graphic form, in addition to the common findings across districts. And the guideline was released by the Honorable Lieutenant Government during a state health event. And in phase 2, UT completed the assessment of its 80 CSCs through this ODK application. And the phase 3 is under process, so we are going to start this process for the public primary health centers. So these are some of the snapshots of these tools, how we operated this and how we got the results from this. It provided the detailed section-wise status of each verification criteria. Then auto calculation and score-based categorization of standards was done. Facility performance monitoring via interactive charts and graphs was developed. Then facility-wise action plans, how to fill those gaps and identify against the identified gaps was also prepared using this ODK toolkit. What is the potential for? There is a huge potential to scale up this initiative for assessment of various programs and schemes, and can be replicated easily in other states and union territories as well. The application can be used for other programs for a rapid assessment of those programs like comprehensive primary health care, maternal health, child health, non-communicable disease, for taking any midterm course sections so that we come to know where we are. So accordingly, we take the midterm course corrections. Using ODK application minimizes errors in data analysis and saves data on runtime basis. And the process of data collection analysis is swift and is easy to access, and allows the permissibility to migrate data from one platform to the other. And this tool helps us to generate the dashboard to have a snapshot of the findings and domain-wise comparison with other facilities, so that we can compare one facility with each facility, and accordingly we can rank those facilities and select those low-hanging fruits in the first instance, where we can actually fill those gaps to strengthen the public health facilities. What are the outcomes which we envisage through if we are able to make these our health facilities as IPHS compliant? We can have improved access to healthcare services through all the public health facilities. As we all know that in J&K, almost more than 95% of the patients are being catered through the public health facilities only, and the presence of private sector is very less in our setup. Then we can have an established continuum of care with assured referral linkages, availability of surgical and critical care services, because they are one of the important aspects of this IPHS compliance. Then diagnostics and drugs as per the essential drug list, so that we can have reduced out-of-pocket expenditure. Then improved quality of services through robust accountability framework we can have, because it also have that all the facilities should be national quality assurance standard certified, or the Lakshya certified, or the Muskan certified facilities, which are the quality initiatives of the Government of India. Then achieving the goals and as envisaged under National Health Policy and the Sustainable Development Goals, for working towards the achievement of the universal health coverage. Thank you, and open to any question or.
Thank you, Dr. Very good project. No specific question from my side to ask. Thank you, please.
Yeah, very noble work and commendable. No specific question. Thank you.
Thank you, sir.
Okay. Thank you for giving this opportunity from the Labor Department, Government of Tripura, and the Labor Department. Here I'm going to present a single window portal in relation to the Nirman Shramik Sahayak Prakalp. We are having a Tripura Building and Construction Welfare Board is a statutory organization in which we are implementing a series of welfare schemes to the building and construction workers, starting from their womb to tomb. We will call the benefit which start from the birth of the child of a construction worker to till his death. We'll have a series of welfare schemes, and these schemes will be provided to the registered construction worker. There are some restrictions or some guidelines to make a construction worker eligible to register under this scheme. And after that registration, he has to keep his registration active, where he has to work minimum 90 days as a construction worker, and he has to submit his subscription 20 rupees per month to be active in the scheme under building and construction worker to get the benefits. Like we implement, like as per the instruction of Honorable Supreme Court, like they have given a series of instructions to improve the scheme. That is, we call it as model welfare scheme. It's an umbrella scheme comprising of many other welfare schemes. Let me brief you that one scheme is marriage benefit. We're going to give 50,000 for the marriage expenses of a female construction worker and a daughter of a construction worker, and the maternity benefit we're going to provide for the female construction worker and also wife of a male construction worker. And again, here each and every scheme there are having a certain rules and guidelines to implement all these schemes. And education benefit or children of a construction worker, maximum up to 2 will going to provide them a benefit. Like after the they will getting registered, the minimum after 6 months of the registration, they are eligible to get this education benefit. Like class 1 to 5, they will have a different each class and each different type of education qualification. Per year we are giving a different amounts for the per year for the benefit of a construction worker. These are all the different like post matric education assistance and mainly for their post graduation. And one more thing, like recently we have implemented in association with Ayushman Bharat, where my building and construction worker, if they don't have Ayushman Bharat the card like Ayushman Bharat Yojana, if they are not covered, and we're going to bear that 5 lakh expenses from the TOBC board for the construction worker, and we are having an MOU and we are implementing this, implementing in association with the Ayushman Bharat. For all these, like why I'm giving the disability benefit, permanent disability, and the loan advances we are giving, a pension benefit and death benefit. Like for example, we are giving up to 2 lakh in case of a natural death if a person dies before 60 years. If we met with any accident, 40 lakh, and funeral assistance we are giving, and other scheme like skill development. These are there as my previous slides. It clearly shows there are n number of benefits and people are will going to get. But as we have seen till the 2020-21, there is no digital database. Like all my district people, they are the registration authority. Centrally, there is no central database, and like eligibility of each scheme has been verified through physically in a register. And the subscription each time for the registration, they have to travel to the labor inspector in the block, and they have to go to the district. Then they will get the registration. That registration is also not digital. And again, after that, to keep that registration, they have to pay 20 rupees every time. For that, they have to all the way from their village, they have to travel to the particular bank or collecting a challan from the office. Like during this process, many of the construction workers, because of the complex process, then they used to lose their lose their registration, activeness of their registration due to non-payment or keeping their. Therefore, most of the eligible workers, they never used to get the scheme benefits which we are offering through our Nirman Shramik Sahayak Prakalp. In order to overcome this, we have planned in association with CSC SPV, we have come up with single window portal where registration will going to happen. A construction worker, the one thing again in a registration, new registration, and we also plan to bring all my offline registration workers, cards has to be digitized. That we have that we're going to have a comprehensive database. After that database, we have integrated a payment gateway, and then each and every person, they can pay their subscription by sitting in their village. Because I'm happy to share that each and every Gram Panchayat I am having a CSC. 98% of my Gram Panchayats, I am also director IT. 98% of the Gram Panchayats, we are having a common service center where they can pay their subscription based on their validity. After that, the next is the application. There are different rules for each and every scheme which I have presented earlier. There they can directly apply from their village. They can apply through CSC or CSC. They can apply. And if they, for the application, there is a mandatory, there should be active registration, subscription should be paid, automatically it will in the back end, whether they are eligible or not, it used to be verified. And again, my database is again integrated with my other ration card ID we are capturing, and again ration card ID backend which has identified with the Aadhaar. And one more we have integrated, again, it has been identified through the other. Like these, therefore, my database, whatever will go, the digitized database will going to be very clean, and therefore the building and construction workers will going to get like eligible building and construction workers will going to get a benefit, and they can keep their subscription, keep their registration active, and they can get the maximum benefit from the. That is the reason we have opened this like single window portal. This support digital certificate we're going to give, and challan form directly they can fill, and then different marriage assistance, application for financial assistance for the different schemes, educational assistance. These are all things in a single window. It has been given, and this is a form where it has been integrated with the e-Shram, and each number we are capturing, since e-Shram has been is a universal account number for a non-organized worker. It has been very authenticated with the Aadhaar. That will help us in identifying whether he is an unorganized worker. All building and construction workers are unorganized workers, but not necessarily all unorganized workers are building construction workers. That is the one thing we are using here. Like till 1.1 lakh beneficiaries exist in the state, but because of the complex offline process, we are they were not in a position, they are not registered. Now 34,285 beneficiaries. Because 1.17 lakh, there may be a ghost beneficiary. Actually, the workers may not be a construction worker, but offline they have entered into our physical registers. But when we started digitizing till date, after launch of this portal from 20th October, we have digitized around 34,000 beneficiaries. Data has been digitized, and now they are applying, that's paying their subscription directly from the portal, and they can apply for any of the benefit which I have told, if they are eligible through this portal. And like 2,165 applications has been already received for the different benefits, and we have disposed almost 1,684. And earlier, like as I have already told, because of the laboriousness and non-availability of online application, the people used to travel to the different labor inspectorates and banks to keep their registration active and to make their to apply for the different benefits. Now, because of this online single window, and which is available in their doorstep, that is CSC, this has made the people ease of living, like construction workers, because one day losing their salary and coming and making this payment, and that is the main issues they used to face. And now, because of the smoothness of the single window portal, they can keep their registration active and they can get the benefits from the Nirman Shramik Sahayak Prakalp. Thank you.
Thank you so much, sir. I would request to our jury if there is any question or suggestion.
Very good initiative, sir. In fact, can you share us that how many beneficiaries have registered so far? I think you have indicated 34,000, and 1,600 have been disbursed the amount. Is the impression right?
Yes. Around like 2,000 people they applied online, and among this 2,000, around 1,600 we are already disposing their applications.
Okay. A second issue is
Through
that
online.
most of them are not so educated. That is true. How do you convey them they are eligible for such and such benefits?
No, we have engaged a dedicated agency for IEC activities, like dedicated agency in which like site is reaching, because I'm having a database, physical database, village wise. Like we have given task to this agency to reach out to them, and we have made a and bills, and where these people can this and identified all these construction workers has been mapped, because these construction worker villages around only out of 1,100 GPVCs, around 600 plus GPVCs we are having concentration of this construction worker, mainly in and around like municipal council and Nagar Panchayat areas. And they we have targeted them, and there we have done dramas like street plays, and like we have run a campaign like Pratigare Sushasan. In that campaign, we have reached to each and every village in the Vikas meetings, we have told, and that is the reason like 35,000. Now we used to claim 80,000 people, construction workers. When we go for digitization, e-strum and other authentication, now I am not even reaching 50,000. Like the people used to tell I am a construction worker. Like now after that we getting the certificate from engineer or from my labor inspector verification, and that will come in a database. Now I am identifying like there are many like false beneficiary, like the ghost beneficiary has been eliminated. Now 34 to 35,000 maximum I can reach 50,000. They are my construction workers, and they like they may get some 50,000 or 50 the 55,000 will be my target, and around 25,000 every year they will going to get the benefits, one or other benefits. Normally we are spending, initially we used to spend 10 crore. Now because of the Aishman and many other model welfare scheme, there is a possibility we're going to spend up to 20 crores. That is the reason before implementing this model welfare scheme, we want to have a digital database. Without this digital database verified through Aadhaar or my ration card database, we can't implement, and it will be questionable, like physical register से implement नहीं हो सकते करके we have started this.
नहीं, ये बात तो सही है कि भले ही चाहिए slow, but it should have its own credibility. That is more important, because after it will go a long way. So it is better to correct each and every database at the beginning itself. Very good initiative. Thank you, please.
Sir, preparing a digital database and then communication among various departments is very critical. So since internet connectivity in Northeast is poor, so how do you take up this challenge?
Sir, that is what I'm also director IT. Like I'm in a dual charge. Now by end of March, there is a project we are running 4G saturation. Like more than 80% of my villages are having a mobile connectivity. Only 20% shadow area, which is there is a issue. For that, we have started a mobile CSC. Like this application, they can take their application, the CSCs. There are 27 mobile CSC vans we have implemented. Wherever my physical CSC is not present, because my small hamlets, 20 families are staying in one place, 15 families are staying in other place, where common service center is very difficult to establish, because he can't run a business like he is a village level entrepreneur with that small limited beneficiaries, he can't run. For that, we have supported through Northeastern Council funded project, like where we can cover 12 GPVCs. In a week, single mobile van with complete infrastructure. Like all the there will be a router with all the Jio, Airtel, whatever the available network you will going to use, and again it is being implemented to my CLFs, like cluster level federation and SHGs. They are like reaching to the place, and most of the connectivity Tripura, as such Tripura connectivity, since we are the state after the first and second international internet gateway, we are having a third international internet gateway through Pakistan. Like we are getting a 10 Gbps link, and where my entire internet connectivity and speed is very good. And we are having recently one Nixie node, like internet exchange point has also been implemented in Northeast, and the internet speed and like coverage, there is a issue 20-25% by end of March or by end of this 2023 December. It's a 4G saturation project, 170 towers the BSNL Government of India's project will going to cover. Like we can't wait for a thing, like we can reach out to them and we can make the digital database. Otherwise, it's very difficult to implement these social schemes. Like there will be duplicacy, there will be a issue of authentication. That is the reason, like we went like more than like wherever my construction workers are staying near AMCs and municipal council areas, it will not be a much issue in digitizing my database and getting the application filled up through online.
Good work, sir. I wish you all the best. Thank you.
Thank you.
Sir, as you are all aware, there was a huge crisis created by the COVID-19 second wave due to influx of COVID-19 patients in all across country. Next. And the crisis was so huge because the lives of so many patients in hospitals, in nursing homes were at stake. And we also faced this challenge in Chandigarh. And so there was a need for some innovative management in oxygen, as the quantity and the generation of oxygen were limited in every city and every state. And the rationale was because of the sudden increase in oxygen demand due to surge in the COVID patient during second wave, along with the supply of liquid medical oxygen was limited, sir, because there was rationing by the government of India. Every state was allocated a limited amount of liquid medical oxygen, and Chandigarh was allocated 20 metric ton of oxygen for a daily use. And there was almost nil oxygen generation in the entire UT Chandigarh, sir, because there was no oxygen plant in the city. The manpower was inadequate in oxygen therapy, that is rational oxygen therapy, sir. The oxygen bed, ICU bed, oxygen cylinders, and the whole infrastructure was inadequate to cope up with the huge load of the COVID patients, sir. And there was a challenge in transportation of liquid medical oxygen also, sir, from the vendor to the city, because that was a very challenging time, and the liquid oxygen tankers were attacked on the way, and there was pilferage and all that. So there was a challenge in transportation of LMO also, sir. And along with that, sir, there was a pressure from the public, media, and administration, because the crisis was acute and the lives of patients were at stake. So enormous pressure from all across, sir. And to fight this situation, the solution implemented by us in Chandigarh were there was a oxygen team of expert. Audit team was constituted in Chandigarh, which was constituted of 2 anesthetists and 1 PCS officer. This team trained all health professionals in private and government hospitals in rational uses of oxygen, because oxygen was being misused in many hospitals, sir, because the requirement for oxygen in every patient is different based on the chest condition and the condition of the disease level. If a patient of a lower disease load is given oxygen at a higher rate, it will not benefit the patient, but the extra oxygen will be wasted in the air. So there was a need for training health professional engaged in oxygen therapy in a rational usage of oxygen, so that we can conserve the precious gas, so it can be used for the other needy patients. For that, we made special posters, videos, WhatsApp messages, and conducted seminars in all the government as well as the private hospitals, lectures. We visited all private and government hospitals for on-site training and trained staff in proper usage of medical oxygen and oxygen masks, and in which position patient should be oxygenated and what flow rate should be used for the different types of patients. Then based on this, sir, a oxygen audit report was prepared for the Chandigarh. Oxygen consumption by each hospital was assessed by this team, of which I was a member, being an anesthetist, and every hospital was assessed based on the bed occupancy of that hospital. So a detailed oxygen report, audit report was prepared, and the hospital found using excessive oxygens. There were punitive actions were also taken against those hospitals. Then a team of experts was deputed at the LMO sites from which the liquid medical oxygen was transported to the city, because there were transportation problems on the way, the traffic jams, and the chances of the attack on the way was there, because it was coming from the Himachal. So a team was posted at the vendor site, and every oxygen tanker used to be escorted by a police pilot team, so that there is no transportation delay and the liquid medical oxygen reaches every hospital in time. Because the crisis was so acute, if the tanker get delayed by even an hour or two, so there were situations the patients were at risk in hospitals. And in cities, there were vendors for the oxygen cylinder were selected by the administration. The public could procure oxygen cylinder from these vendors at a controlled price, and the prices were being monitored by the special team. And any vendor found charging more than that, the fixed price, the legal action was taken against those vendors. And for the ease of public, sir, because there were patients at home which needed oxygen, because they were like cancer patient and old age patients, they were advised oxygen by their physicians and their hospital, and they were managed at home, and they faced a tough challenge in procuring the oxygen cylinder, sir. So we in Chandigarh, sir, we prepared a e-permit system. This was an online system, and anyone could register its name and just upload the prescription of a doctor, and he could procure the cylinder from the vendor. The vendor will deliver on the control price of the cylinder were delivered to the public for home usage, sir. And necessary orders and directions were passed time to time by the administration, sir, for benefit of public, so that there is no pilferage and there is no overcharging for the oxygen. Then, sir, there were because the cylinder and the concentrator and the LMO tanks were not adequate, so immediate, urgent procurement was done for the cylinders, concentrators on donation basis and from the government of India or the local purchaser, just to boost the oxygen management infrastructure, sir. And oxygen beds were increased in every hospital, ICU bed were added, and the ventilators also added, because many patients in the advanced stages, they needed this critical care services, sir. And another 100-bedded hospital was established at Punjab University, Chandigarh, sir, which was managed by the Indian Army, and we had the responsibility of supplying oxygen for those 100-bedded hospitals, sir. And we created 8 COVID care center with oxygen facility in UT Chandigarh, sir, because all patients were not getting bed in the government hospital, the private hospital. So the patients with minor disease load, they were managed in at these 8 COVID care center, and they were established with the oxygen facilities, sir. And to boost because the oxygen generation was almost nil in the city, then we installed 3 PSA plants in city in a very short period of time, sir. During that crisis, sir, Chandigarh was allocated 3 pressure swing adoption oxygen plants, sir, which generate oxygen from the ambient air. And these plants were installed in a very short period of time, and Chandigarh, the first city in the country to install the first PSA plant, and that efforts was appreciated by the ministry. And in the first phase, we were able to generate oxygen in the range of 1600 liters per minute with the help of these PSA plants. They were installed in 3 main government hospitals, sir. And to spread the message fast, because the patient were coming very fast to the hospital, and the bed were getting filled very fast, and the details.
Sorry to interrupt you, sir. Please conclude, sir. You have 1 minute more.
Okay, sir. Okay, sir. And the outcome of this disease, sir, because of this audit and the training purpose, we could save 25% of the oxygen, and which was used to supply oxygen to the private hospitals, sir. Otherwise, private hospitals were facing challenge at that time, sir. And the 3 PSA plant and the 2 private hospitals also motivated to install a PSA plant in their own hospitals, sir. And so every patient received bed and oxygen wherever required. Even private hospital was supplied oxygen from the government's. So in this way, a robust oxygen infrastructure was created, and with a good trained manpower, and a digital framework was created in the form of e-permit system and the WhatsApp groups. Challenges faced, sir, the challenge was installation of PSA plant. The time was very short. The training all professional was challenging, sir. And assessing of oxygen of every hospital based on the bed occupancy and creating their supply order daily was challenging. Timely delivery of liquid medical hospital, every hospital was a challenge. And twice a day de-icing of the LO plant vaporizer, sir, so as to create the optimum gaseous oxygen from the liquid, and keeping a check on the price and preventing any mishap and the disaster during excessive use of hospitals, sir. Achievement, sir, there was no death in entire UT Chandigarh during that crisis, and we have achieved 100% on the ODS and the OxyCare portal and the Oxygen Stewardship Program of the Government of India. Successfully conducted all PSA plant mock drills as per directions of the Government of India. Successfully trained a batch of engineering students at our government facility. Created a robust oxygen infrastructure, sir, and a strong digital framework for this facilitation, sir. And now we have 7 PSA plant in whole of the city, sir, with 5200 LPM output, sir. And for our work, we received many appreciations, sir. Chandigarh Administrative State Award. Honorable Prime Minister also appreciated Chandigarh model and advised other state and UT to follow it. Our study has been nominated for the PM Excellence Award and the prestigious Subhash Chandra Bose Disaster Management Award 2023, sir. And Chandigarh audit team is the only audit done on the medical gas, and which has been appreciated by a reputed medical journal and has been got into the print and published across world, sir. And oxygen management of the state has already been selected as the best state practice, and it has been nominated for the state innovative in the health category, sir. These are some news items and the appreciation by Prime Minister and nomination, sir. Thank you from my side, sir.
Yes, it was a very difficult time during the second wave of COVID, and everybody worked hard.
Yes,
and whatever actions you have taken really they were needed at that point of time. So no specific question. Thank you very much, sir.
Thank you, sir. Thank you. Thank you.
So what we are presenting today is a case study of preparing need-based and implementable GIS-based development plans through participatory approach. So the structure of the presentation is project overview, then the challenges faced before implementation and also during the implementation, and then in terms of solution, how the solution is to be viewed as need-based, implementable, and geographical information system, how it is used for achieving the things. Then outcomes, then benefits of what we have done, and case study in case of one town, how we have done, gone ahead with that, and the way forward for this exercise. So if you see the process of development plan in Maharashtra, it is mandated by the Act that every urban local body, after its formation within 3 years of period, they have to prepare a special plan called development plan, keeping in view the needs and requirements of the town for next 20 years. And it's also subject to revision in 20 years. Now, we are comparing the two methods. It's conventional method we used to do before for preparation of plan for each town, and this exercise is being a GIS-based plan preparation for 106 towns concurrently. It's very huge task we have done this year. So it has reached every district of the Maharashtra. See comparison, the timelines, earlier we used to take 3.5 years, 3.5 years. Now we have done it in 2 years. it was not in GIS, it was all can say conventional method. Now we have taken the GIS based preparation for all 106 towns at the same time. The earlier version was without participation. The participation limited we used to take only after the publication of the development plan. Now here we are taken it prior to preparation of the development plan. This is an additional thing we have done. So we are done in case of GIS all Amrut compliant plans with 600 plus layers. And earlier we used to take standard planning norms for all towns without taking into consideration whatever requirements of particular town or town specific character. Now we have evolved, we have asked town planning officers to evolve themselves town specific planning norms, keeping in view the town as a specific entity. Now earlier there was no standardized geodatabase and layer structures, and there was no standard operating procedure. Now we have made, since it was the GIS version, we have made that there is a SOP made in place so that it helps our people, our officers to monitor at the same time for the agency also which were deployed to undertake that project for carrying out the objective. And the concurrent interventions like the town-based norms to be evolved by the town planning officer, the suitability of land for particular purpose with the help of geographical information system, and yes, the public participation prior to preparation of the development plan. Now, what are the important aspects? So I already told that it was like when we go on for a kind of GIS based plan, it is adding to the data analysis, data integration, data correlation. And what earlier used to be there, that there were apprehensions in terms of reservations in the development plan. There was a feeling in the minds of the common man, the plan is not for them, the plan is not prepared by them, but somebody, the expert, is imposing the plan on them. So this was a kind of, and there was leading to a resistance kind of thing, and leading to a number of objections to the development plan. Also, when it was, you can say, more than what was adequate provision made in the plan, the implementation level of the development plan was too low. And yes, it was like mathematics. They used to take that same planning standard for all types and scales of town, and contextual requirements were not given that serious thought, and they were very less reflected in the plans. And there was no vision taken into account from the people that what they want for their town, and therefore there was a lack of awareness about development plan of the city. At the same time, in terms of the urban local bodies, there were shortage of funds. The budgetary priorities were not focused on the development of various provisions of the development plan, like reservations and other amenities. And yes, the stakeholders' participation and need-based town-specific norms, both the things are not mandated by law. So need-based town-specific norms are a philosophy of planning one. The town planning officer has to evolve of his own. And the stakeholder participation is not mandated, still not mandated by law. But it was a voluntary intervention made by the Directorate of Town Planning in Maharashtra in the interest of collaborative vision. So importance of participatory approach was filtered down to the local officers. Yes, when we introduced this concept, so this was like initially taken that this was an additionality. Why our senior is telling us to go with this? This is not required by law. Then why should we spend such of a time and energy into it? Now we convinced our officers, and it has trickled down with one-to-one interaction, and it has made that we have made it a point that senior officers attend every local meeting, so that it becomes a kind of culture that yes, senior officers are coming to a small town of 20,000, 25,000 population. So earlier the public participation was limited to filing suggestion objections after publication of DP. This is the DP we have prepared for you, and now tell whether you have suggestion or objection. It was like just a formality kind of thing, and then there were n number of objections, those used to be received, and ultimately that system did not used to capture the needs of the people. It was like expert-driven version without public participation, and then impacting negatively the plan's credibility. Now, what should we call as you can say plan which is a need based. It is the vision co-created with community. It's not the vision of the only expert or the urban administrator. It's the vision of the town, what the town needs, what the people need. It is co-created with collaborative interaction. Now it is satisfying the needs of the community, and then you have to build on the opportunity of the town, and you have to plan it based on the situational analysis. It is not to be based on you can say one fits all approach. Then why it is important? Because it nurtures the sense of belongingness in the common citizen. Why? Because it's my plan. Yes, my small thought, my small intervention, my small suggestion is taken into account. Yes. Now what we have done, when we interacted with the people, whatever they have suggested, we have made a list. And when our town planning officer prepared a plan and handed it over to the local body, it was made a point that town planning officer presents it to the general body of the ULB, and keeping in view and telling them that yes, this was the list which has come out of the interaction, and then these are the things we have provided in the plan this way. And this we could not do because of these restrictions, or this can be done in terms of other way of doing it, not as a part of plan, but maybe some administration interventions. So it has helped. It is leading to inclusive development. It is good for inclusive development. It allows community to positively participate and strengthens the feedback culture. So this is a good change in the department. Yes, we should get feedback from the people and then reorient our thought so that it goes with the context of the town. Now, how we have done it? It's actual physical meeting, and at the same time we have provided Google Forms before preparing, so that we can get those who could not attend the meeting physically. We could get their feedback in the form of Google Form. It has helped us in having the analytical data readily available from the Google Form. Based on that, we made a SWOT based on the above, and then parallelly our town planning officer has done town specific norms evolved based on that SWOT, and then we have made it a point that the philosophy of planning or the SWOT analysis or the glimpses of interaction, those should form the specific chapter in the development plan report, so that a common man whomsoever reads later on, or anybody who reads later on, should be knowing that how the things have happened and what are the immediate and long-term needs. Next is how implementable plans. In case of implementable plans, it should what is to be called as implementable plans? It has to be acceptable to users. It should be financially feasible for planning authorities, and it should be just adequate. What town requirements? It should be just at par with that, nothing beyond that, so that it becomes a practical kind of planning proposals. Now, why it's to be called implementable? Because it impacts the level of implementation. It enhances the possibility of transforming the plan onto the ground, and it removes the apprehensions in the minds of the people regarding the reservations or proposals in the development plan. And yes, much important thing is, because there are some restrictions, you can say unwarranted restrictions, if we go for more number of reservations.
Sorry to interrupt you. You have a 3-minute more, so please conclude.
Yeah, please. Okay. So these are the interventions we have made. We have the government directives to go for a GIS-based DP program in a time-bound manner in the 2 years period. This is a draft questionnaire which we have given in the Google form, and directives by the directorate for devising town-specific norms by the town planning officer. This is outcomes which we have expected. That inclusive development. So it reflects the development plan, reflects the aspirations of people. It impacts the development plan by enhancing the public participation. It has outreached the planning process to grassroots levels. It has achieved the holistic development through the chain of small interventions, concurrent actions, and yes, the vision of common man embedded in the plan. And it has incubated good planning practices in working of the department as well as in the domain of the common citizens. Now it has increased the effective implementation of development plan, specific timelines ensuring completion in time-bound manner. It has dire need of town is recognized, and character of town is kept as a central theme while formulating the planning proposals. And in case of transparency, it is intervention at the right time for the DP, because most of the 106 number of towns, they were newly formed ULBs. So it was their first kind of development plan with this kind of culture. It has led to removal of misconception. Faith in the system has increased. It has reduced the resistance to the development plan in terms of number of applications getting reduced to 50%. And it has led to accuracy because of the GIS tools like standardized GIS layers and standard operating process. What are the benefits? It is planning by the people, with the people, and for the people. It is Google form questionnaire. It is built-in analysis, capturing the requirements of the town, building on potential strength of the town to harness its opportunities, and ensure useful necessary reservations for effective implementation of DP, and 57% reduction of time preparation of the DP, and Amrut compliant GIS layers ensured compatibility of plan and generation of thematic specialized spatial data on a single layer. The last two slides. So way forward, so just given in case of Java town, the way we have given stakeholders participation. So the GIS layer development plans, we have got 600 plus layers. The analysis of layers, we are expecting it to happen, lead to some decision support system in terms of urban governance, in terms of urban planning issues, some dynamic issues. At the same time, we are in the process of preparing 17 modules, supervisory modules, which are based on various constraints of the MRTP Act. So there would be sharing of master database in case of those supervisory modules, also the layers which are there in GIS format. And out of this, you can say that there is one of the 17 models, DP preparation model, where there is a software application to guide the total process of DP monitoring and all that. It will lead to a kind of rational decision making in terms of DP reservations. At the same time, it will lead to many decisions which will come out of various layers in the GIS as well as these supervisory models. And what we think of, yes, all the future plans, not only for the urban local bodies, the census towns we are also preparing. Now the demands are coming from various Jilla Parishad that we should prepare the development plans for census towns on the same philosophy. We can replicate those things there also. Then the standard operating process will get evolved again when we improvise in the next phase. Then similarly, just like GIS-based development plan, we are taking a mission in next 1 or 2 months, GIS-based town planning schemes. And we are also planning under the digital planning cell, which we are forming in next 1 month, so that we can generate various thematic maps, which can be provided to other departments of the state for larger usage. And yes, we expect a dynamic updation of DP, like the building plan monitoring management system. Whatever permissions will be granted, those will be with the lat long will go into the GIS mapping, so that the next version of the plan will have some kind of value prepared in terms of whatever is authorized development that has taken place. Thank you.
Thank you so much, sir. I would request to our jury if there are any question or suggestion.
Thank you, sir. Very good initiative. You have introduced public participation as well as the feedback element in the planning process. That is, I am very happy on that account. Can you share us with just 2 examples where public participation has made 2 innovative suggestions which has altogether changed your planning or development plans?
Yes,
just
sir.
two examples.
Yes, sir. So in case of Jawar, the stakeholders' reaction was that the tribal people are dominant in that town. So they had said that there would be a good thing if there is a tribal art kind of village scenario created in the development plan. So though we are preparing it in the form of urban, the culture of the Adivasi people should be reflected in the various community areas which we are developing. So we are trying to tie up with tourism department and the tribal department of the state. Even from those departments we have interacted with how best we can do with their by converging the schemes from their departments, those departments and the urban development department. This is one. And second is like in Polatpur, where it's all most of the time it gets flooded. So the Bazaar area, they wanted a small intervention that they want common toilets very small requirement. So whatever we could specify our police chowki in just like 3 or 4 guntas of land. So those small interventions also we got from the stakeholder participation. And yes, they have also suggested what place we should place. It's not that we are the best planners. So they know what place, what is required. So it made us very simple.
Sure. After all, you are doing for the public, and public participation is extremely important. I would rather suggest one more step, that you also involve them in removing unauthorized construction.
Oh yes, sir.
That is a major problem in urban areas. Anyhow,
Yes,
thank you very much.
Yes, sir.
Thank you, please.
Yes, sir.
Okay.
Thank you.
Good efforts while involving public as well for planning purpose. So have you built in some grievance mechanism?
Sir, not grievance mechanism. We are in the process of preparing grievance mechanism through our website. But in terms of development plan, this is the first time we have introduced this concept. And just I will say from the month of August, September till November last year, 2022. So grievances, those come after the DP is published. So we have experienced that earlier we used to get, say, for a small town, even used to get 200 or 250 number of objections. Now it has reduced down to 2 digits, 60, 70 or 50. So it has reduced to 30% of what we used to get, because most of the requirements are captured.
Okay, good enough. Thank you very much, sir.
Yes.
So good morning. I'll just like to start with the presentation. So Punjab was the first state which started a state level intervention program, Mukhyamantri Punjab Hepatitis C Relief Fund, in 2016, before the launch of national program. It was the first of its kind program in the country in a decentralized manner, where hepatitis C patients were screened, tested, and managed at 3 medical colleges and 22 district hospitals at that point of time. Now, the number of district hospitals have increased to 23, and PGI Chandigarh became our model treatment center, which is giving us technical guidelines through Department of Hepatology. At that point of time, when it was just a state initiative, so we took the support of the existing manpower, no another support from any other department, other thing. So existing medical specialists, medical officers, lab technicians, pharmacy officers, and data entry operators, they were involved. So I had been part of the national team. So national program was launched in 2018, and finally Punjab adopted the guidelines in September 2018. So if I look at the journey, we have already completed 6.5 years of this program, and the data is quite robust. In the main aim of the Government of India, international level, if we look, the aim has been elimination of hepatitis C by 2030. And if we have to achieve that goal, we have to decrease the viral pool in the community. And the maximum pool is found in the high-risk groups. The maximum high-risk group in front of us is the persons who are already HIV positive. If we look at the data, the positivity of HCV co-infection among HIV is quite high in different studies. It ranges from 10% to sometimes even to 40 to 50% of the total individuals. So it becomes a two-way strategy, that it's a two-edged sword. The person is already having HIV infection, and HCV co-infection can be very high. So taking this program when we were implementing, so the screening on management of high-risk group, that is persons who are already HIV positive, was initiated. So to start the project, we collaborated with Foundation of Innovative New Diagnostics, FIND, with whom our Honorable Health Minister of that point of time had an MOU in 2017, when we started the capacity building of the staff for implementation of this program. And in October 2018, we actually started implementing the screening and the management of the HIV positive patients. At that point of time, we had 13 ART centers, which were located in the map. If you can see, So 13 ART centers were located, and FIND provided us RD kits for initial screening and 4 gene expert machines, which were placed at 4 sites, and all ART sites were linked for sample transportation, and patients were screened with that. That was the first intervention in the country where screening of HCV among HIV patients started at ART centers at itself. So patients were screened with RDT kits, and viral load testing for confirmation of whether they are having viral load in them was done with gene expert machine. So I must tell here that all the persons, if a patient is positive with hepatitis B or C, the antibodies, they remain throughout the life. The person, whenever we test anti-HCV antibodies, they will remain positive throughout the life. But then we have to test the patient for viral load, whether viral load is there or not. If there is viral load, then the person is infective and we have to treat. So all the baseline tests were done as a free under the free diagnostic scheme of NHM. So it was 0 out of the pocket expenditure for the patient. So HIV patient positive was not paying anything. We were providing them screening, counseling, baseline test, and referral of treatment at the linked hospitals under the program. For this intervention, we developed 3 documents. One was HCV treatment card, which was first of its kind in the country, where all the records were digitized and made on a MIS portal, and 1 copy was available. Then a pink card was available and made available to the patient. This was known as SVR. Once the patient completes a treatment of 12 to 24 weeks, we have to test the viral load after 12 weeks of the completion of therapy to see whether there is still a virus in the body or not. If there's no virus, then the patient can be declared cured. So we developed 1 cure certificate for the patient to just give them the strength that they have been cured of the disease, with mentioning in vernacular, if they are indulging again in high risk practices, they can still get the infection back, but they are currently cured. In 2020, the state government took over the project when FIND completed their project. Now the program is being run by the state government on its own under the national program. And under the program, screening and everything from viral load testing is provided free of cost. I would like to mention, with the advent of this program, the viral load testing, which was available in the market to the tune of 4,000, the prices has come down to 850, with provision of 1 lab technician by an accredited lab with which services are being provided. In February 20, we took the capacity building of all the staff, medical and paramedical, again to hand over the project to our own staff. During COVID pandemic, when there was a complete shutdown of all the services, the hepatitis C treatment management at ART centers continued. We put 653 patients on treatment during COVID lockdown with the help of our peer support and ART staff. And with state government intervention, we declared all ART staff as the treatment centers. So the patient will not have to go out to get treatment. So the patient screening from management and everything was provided at ART sites. And we started multi-month dispensation of the drug, so that patient who's coming will be given as an HIV 3-month treatment. We were giving 3 months treatment for HCV, and the patient were tracked by peer support after counseling for these patients. Now, when we 2020 and 17-18 we started, there were 13 ART centers, which have now increased to 23 in the state. So as the ART centers are increasing, we are enrolling all ART centers in the program. Staff is sensitized, and all the ART and all PLHIVs, high-risk groups, are being screened at ART sites so that patients they do not get away and their default rate could be decreased. If we look at the positivity rate, it is from 10% to almost 51% at one of the centers. So it's a range different of positivity of 10% at one center out of 23, and one center having 51%, with average of 24% of positivity of hepatitis C among PLHIVs. So we can see the quantum of the infection which was already there, which we were able to detect with this intervention and put the patient on treatment to decrease the further spread of the infection. Out of the total, almost 52,000 PLHIVs. It's a very dynamic population where the new patients are added every year. Some they do die, or they get default, or they shift out of the country or something. The dynamic population is around 52,000. Out of those, 91% they have been screened now, and out of those, eligible patients have been put on treatment at all the ART sites. With success of hepatitis C program in 2020, we also initiated hepatitis B screening of these patients. Although hepatitis B positivity is slightly lesser than HCV, but still it's a potential risk for these patients. We started hepatitis B services again at these centers. And another intervention which we started, all the HIV positive patients who were hepatitis B negative are now being given hepatitis B vaccination free of cost. State is procuring that and providing to these patients. Till now, we have 33,874 persons who are negative of hepatitis B, 792 are positive, and out of those, more than 25,000, they have already been vaccinated, so that in future, they will not have chances of getting hepatitis B infection. So it was another intervention of its kind. With this advent, we have done the data analysis of harm reduction. The maximum cause of infection among this is IV use, injection drug users, the drug addicts which are using same syringes. Out of the total population of PLHIVs who are HCV infective, 42% they have history of intravenous drug users. So with this, we have now started the program of extended to OST, which I will be sharing in some another forum. So we are now going into harm reduction for these patients as well, taking them to OST centers who are AVDO positive for treatment. In way forward, we are now extended HCV and HBV services to ensure their adherence. We are also planning their trainings. We have prepared all the IEC material in their vernaculars. We have strengthening of multi-month dispensation, so there should not be default. All the records are digitized since the patients, we have to maintain the confidentiality that remains with us. So peer support of each site is in touch with each patient when they are coming for follow-up. So we always know which patient is coming for follow-up, and all the centers, they already know which patient is coming for follow-up. And even if there's a delay of 1 day, the patient is tracked and called back for collecting the next month doses. So we have now linkages to model treatment centers. All the high-risk patients, since around almost 85% patients, they are non-cirrhotic, 15% cirrhotic patients, they are being linked with medical colleges, and there are separate queues and separate days are fixed where medical specialists examine these patients high risk. And the treatment is again initiated at ART centers of the patient. They don't have to travel further or don't have to go anywhere outside. With this intervention, when we have already screened 91% population, so that's been gap of almost 1 year. So we have started practice of repeat screening of all those persons who were tested negative. So that patient, if in that time period has again relapsed and gone for IV dose injection, the person can get infection. So we are doing repeat screening of all the patients, putting them the treatment with a aim. The theme of World Hepatitis Day this year was bringing hepatitis care closer to you. With that theme, we are taking the treatment, screening, and management of hepatitis B and C closer to high-risk population so that they are screened, tested, and managed at ART sites and not being referred. So with this, if we bring hepatitis care closer to these high-risk groups, we will decrease the viral pool in the community, and that will be a step towards elimination of this disease. And with this aim, we have developed this model which is being replicated in many states, and we are in touch with other states also where this is being implemented. And if in future it permits, I'll be presenting another intervention learned from this lesson. We have taken this care now to OST centers. We have started intervention in prisons where high-risk groups are being tested. And now we are going to all the de-addiction centers where IVDs are being treated for testing treatment and management of hepatitis C at the site of management in order to achieve the goal of hepatitis C elimination. Thank you very much.
Dr. Grover, a very good effort.
Yes, sir.
But from your presentation, it is noted that you have already tracked around 50,000 patients. Do
Yes,
you, for the sake of monitoring or further follow-up of treatment, do you manage their database on a digital platform, or what is the arrangement?
So it is a digital platform. Earlier, it was software of state government. Now it is the software of Government of India, which is with NIC, and that data is available digital. I can have the access, districts and the ART sites can have the access of the patients. And all the times we have access of these patients, we are not only doing the management, we are also doing their capacity building and behavior change communication for harm reduction so that disease is not further spread.
Second query is that just like you have mentioned that hepatitis B has a vaccine, do
Yes, sir.
you have or any hepatitis C vaccine also, or it is not available?
Till date, Hep C vaccine is not available in the world. So Hep C is treatable, it can be cured. Earlier, there used to be injection interferons, which were to the tune of around the treatment of 24 weeks used to be of 4 to 8 lakhs. With our intervention, when we started the program in 2016, the cost of treatment for 3 months was 40,000, which has come down to just 5,500. So it is the leap which medical science has taken with advent of orally acting drugs, and the disease is curable, and our cure rate is more than 93%. In general population, in high risk groups, we are still achieving more than 85% cure rate, which is a very big number. Few patients do default when they again go for injection drug use, but cure rates are still 85%. Still, there is no vaccine. So prevention is the best cure for this disease, which we are implementing. So the early detection and putting the patient on treatment will be the best resource for decreasing the pool of infection.
Thank you, Dr. Grover. Thank you, please. Good effort.
Thank you, sir. Thank you, sir.
No specific question. Thank you, sir.
Thank you, doctor. Thank you, sir.